Good evening and a warm welcome to all of you. Our discussion today will be the sex hormones. Part 10 of endocrine physiology. We'll divide it into male sex hormones, discussion of male sex hormones first, and then female sex hormones. The male reproductive system understanding helps us to understand the important physiological concepts, and also it helps us to understand the diagnosis of infertility, especially in males. All right, so the male reproductive system is governed by three important hormones. It is the LH, FSH, the luteinizing hormone, the follicle stimulating hormone. It has got the indirect role that is played. Who controls these two hormones is gonadotropin releasing hormone. All right, so we need to understand what is the physiological basis, what is the relationship between the control of this GnRH, gonadotropin releasing hormone, on the FSH and LH, and how is the testicular cells, in the testis, testosterone is a hormone that is produced. So that is the third hormone that is controlled by, and that is important for the male reproductive system, controlled by the gonadotropin releasing hormone. We'll try to understand the relationship between these three hormones. So the relationship we'll be calling it as the hypothalamus pituitary testicular axis. You'll have to understand this hypothalamo pituitary testicular axis. So we have got hypothalamus somewhere here like this, and then this is the stalk of the pituitary, and this we have got the smaller lobe and a larger lobe of the pituitary. Here in the hypothalamus we have got gonadotropin releasing hormone. This gonadotropin releasing hormone is acting on the pituitary to release two important hormones, the LH and the FSH. All right, now LH acts on the Leydig cells of the testis. Leydig cells of the testis. Here it converts the cholesterol to testosterone and dihydrotestosterone, and dihydrotestosterone, and this testosterone is released into the blood. This testosterone is released into the blood circulation. From here, what happens is there is an enzyme called as 5-alpha reductase. 5-alpha reductase converts androgen to testosterone, that is the dihydrotestosterone. Please remember that in the blood, the dihydrotestosterone is a more active form of testosterone, and presence of testosterone in the blood, it provides a negative feedback on the LH. A negative feedback on the LH. All right, from the Leydig cells, activation of Leydig cells, the activated Leydig cells tend to stimulate Sertoli cells. These Sertoli cells are acted upon by the FSH, follicle stimulating hormone. Again, they are kind of nurse cells for sperms. The testosterone which circulates in the blood in the form of bound testosterone, these are acting as nurse cells of sperm. nurse cells of sperm, and they also secrete testosterone. All right. So the Leydig cells testosterone, some of which diffuses into the Sertoli cell, where it is required for the Sertoli cell function. The FSH primarily stimulates the Sertoli cell. The Sertoli cell produces an important hormone called as inhibin B. Inhibin B. This inhibin B, it produces a negative feedback on FSH. This inhibin produces a negative feedback on FSH. Testosterone produces negative feedback on LH. Inhibin B produces negative feedback on FSH. Please remember this one. The gonadotropin releasing hormone is synthesized in the pre-optic region of the hypothalamus. It is synthesized in the hypothalamus, pre-optic region of the hypothalamus. It reaches the pituitary gland via the portal blood vessels, the blood vessels which communicate the hypothalamus to the pituitary gland. From here, please remember that the release of gonadotropin hormone, releasing hormone, is pulsatile in nature, in a pulse-like manner. It is not released continuously in the same volume throughout the day. Alright, it is released in a pulsatile manner. This pulsatile release of GnRH results in pulsatile secretion of LH and FSH. The pulsatile release of GnRH, it prevents, why is it pulsatile? Because to prevent the down regulation of receptors in the pituitary gland. So it is a way or method of controlling the pituitary gland. So imagine if GnRH is continuously maintained at one single level, then there is no stimulus for the pituitary gland to secrete LH and FSH. This principle can be employed in the treatment of infertility sometimes. If FSH and LH are very low, what you can do is for some time you can give GnRH analogs to the patient, and for say suppose few weeks you can give to the patient, and the pituitary suppression can be done. Once every day the patient receives GnRH in the same level, there is the pulsatile secretion phenomenon is lost, and patient's pituitary is not stimulated. After a few weeks you stop the drug. Once you stop the drug, what will happen is the pulsatile release of GnRH comes back. That results in increase in LH and FSH. That results in normal functioning of the pituitary. So this is how we can treat in certain cases of testicular dysfunction. The LH and FSH is produced by the stimulation of the gonadotropin releasing hormone in the anterior pituitary. LH stimulates Leydig cells, FSH stimulates the Sertoli cell. And what are the functions? Let us try to analyze. So Leydig cells, they express receptors for LH, and please remember these are the peptide hormones, especially luteinizing hormone. The LH is a peptide hormone. So peptide hormone means it requires cyclic AMP for its activation as a secondary messenger. Yesterday I told you one more peptide hormone requires cyclic AMP for its activity. If you remember, what is it? It was, in my yesterday's class I told you paroth hormone. So here also the cyclic AMP is responsible for initiation of production of testosterone in the LH cell. The LH Leydig cell, they produce testosterone, and thus testosterone is secreted into the blood circulation. Please remember this cyclic AMP is responsible for upregulation of certain enzymes like the steroidogenic acute regulatory protein, the star protein we call it, steroidogenic acute regulatory protein. So the cyclic AMP, LH via the cyclic AMP, it activates this enzyme, and this enzyme is responsible for production of testosterone. Testosterone diffuses into the cells of the Sertoli cells now. So this is all about this occurring in the Leydig cells. So now from here the testosterone which is formed, this testosterone diffuses into the Sertoli cells. It stimulates Sertoli cells for production and high concentration of testosterone reaches the Sertoli cell, the circulating levels of testosterone, the circulating levels, now this testosterone also reaches blood. So this circulating level of testosterone is having a negative feedback on the production of LH. It has got a negative feedback on LH. Thus the regulation of LH occurs. So Leydig cells, one important function is aromatization of testosterone. Aromatization of testosterone into estradiol. Testosterone is converted to estradiol, the active form of estrogen, by an enzyme called as aromatase. So these are all the important functions of Sertoli cell. These are all the important functions of Sertoli cell. Please remember that some certain target tissues express enzyme called as 5-alpha reductase enzyme. 5-alpha reductase. This 5-alpha reductase converts testosterone into dihydrotestosterone, just now I told you, and other forms of androgens into dihydrotestosterone. Please remember, this dihydrotestosterone is the most active form of testosterone, most active form of, physiologically most active form of testosterone. What does this dihydrotestosterone do? It helps in development of external genitalia, the length of the penis, the volume of the scrotum, the differentiation into external genitalia, especially in a neonate, in a intrauterine life. 5-alpha reductase enzyme is very essential for formation of the dihydrotestosterone. So first important function of this is sexual differentiation. Sexual differentiation. This is also responsible for increased activity of sebaceous glands on the skin, especially face. Hence, higher levels may prone the person for acne, development of acne. Then it is responsible for synthesis of nitric oxide. This nitric oxide synthesis, especially during erection, helps in accumulation of blood in the penis. Blood flow is increased in the venous circulation of the penis and erection occurs. So the erection is a feature because of nitric oxide synthesis. Nitric oxide synthase is an enzyme which is activated by dihydrotestosterone. Dihydrotestosterone is involved in growth and development of prostate, which is responsible for secretions in the seminal fluid. The prostatic secretions are alkaline secretions. The seminal vesicle secretions are acidic secretions. All right. So prostate development and prostate normal development is who is responsible is dihydrotestosterone is responsible. Dihydrotestosterone is responsible. Next important fact is male type of baldness. Male pattern baldness. Male pattern baldness is also an activity of dihydrotestosterone. All right. Next is the FSH or Sertoli cell. Sertoli cell. Please remember that the FSH binds to Sertoli cells. FSH activates the Sertoli cells via the FSH receptors present on the Sertoli cells, again via the GS cyclic AMP pathway. The same pathway, GS cyclic AMP pathway, being a peptide hormone. The Sertoli cells release an important hormone, that is the inhibin B. Inhibin B. This inhibin B gives negative feedback to the FSH. It gives negative feedback to the FSH. It gives negative feedback to the FSH. All right. The Sertoli cell's important function is it provides spermatogenesis. It does an important activity of spermatogenesis, which is via the FSH, mediated by the FSH. FSH, along with a very high level of testosterone, they act on the Leydig cells to produce certain growth factors necessary for the growth and maturation of the sperms. FSH and testosterone, they induce what is known as androgen binding protein. So because of FSH and the testosterone, what is developed is androgen binding protein. This androgen binding protein helps in maintaining high levels of testosterone. It binds to testosterone and it helps in maintaining the high levels of testosterone. The Leydig cells have an enzyme, I told you, aromatase. Aromatase enzyme helps in aromatization or chain conversion of testosterone to estradiol. Testosterone to estradiol, just now I told you. So similarly, an important important hormone for growth and maturation of sperm is the estradiol. All right. So the testosterone getting converted to estrogen is also responsible for growth and development of sperms. The Sertoli cells, which are secreting inhibin B, it produces a feedback regulation onto the FSH. So these are all the important points you need to understand. So what are androgens? Androgen means any steroid that controls the development and maintenance of masculine features. We call it androgen. What is testosterone? Testosterone is a natural male androgen. Testosterone is a natural male androgen of testicular origin developed by the stimulation by the LH. Testosterone gets converted to dihydrotestosterone by the enzyme 5-alpha reductase. 5-alpha reductase enzyme. Dihydrotestosterone makes the penis, the prostate, the scrotum in the embryo at the embryonic life. All right. So we have got androgen source. The important source of androgen is testis. Weak source of androgen is the adrenal gland. In male and female, both male and female, the adrenal gland, the adrenal cortex, it under the influence of ACTH produces dihydroepiandrosterone acetate and androstenedione. If you remember my class on adrenal gland, I have shown you one pathway. I have discussed one pathway about how androgens are formed. How androgens are formed by various enzymes. So this is all about discussion of important hormones of the male reproductive system. Now let us try to understand what are the age-related hormonal changes in males. Age-related hormonal changes in males. So testosterone, as the age advances, the testosterone increases, peaks from the puberty to adulthood, and from the puberty to adulthood, the testosterone peaks, and after that it falls. So as the person becomes older and older, the testosterone falls. But if you talk about the LH, which is a stimulant of testosterone, if you talk about at puberty, it begins to rise. It reaches peak in adulthood. As age advances, it increases. LH increases. So please remember, with the age, the LH increases. With age, the LH increases, especially following the fall of testosterone. So there is no feedback stimulation. Feedback inhibition is not gone, and LH keeps on increasing. What is the effect of these hormones onto the various functions that they bring about? For example, muscle mass. I already told you that androgens in my class of adrenal cortex, I told you androgens stimulate protein synthesis. Androgen, they decrease protein breakdown, hence they increase the lean muscle mass. The larger muscle mass in males, it is because of the androgens. The exogenous androgens are sometimes taken by people to improve the muscle mass. All right. And this is how in Olympics, in championship, sometimes people take these muscle to improve the muscle mass. And if it is caught in the urine sample that you have taken anabolic steroids, that is the androgens from outside, pharmacological measure, then they will cancel your championship, and they will strip off all the medals that the people have received. So many times we have seen in the news where the sportsmen taking androgens from externally to improve the muscle mass, to improve their performance. Apart from this, how is this knowledge of male sex hormone helping in treatment of infertility? Please remember, spermatogenesis, it is a temperature dependent process. That's the reason why the scrotum is away from the body temperature. The scrotum hangs from the body and it is taken away from the central body by its natural placement in the scrotal sac. The testicular placement is not abdominal, it is typically outside the abdomen. The reason is high temperature is inhibitor of spermatogenesis. High temperature is inhibitor of spermatogenesis. The testis fails actually if the testis fails to descend in a condition called as cryptorchidism. Cryptorchidism. Here what happens is there is the person develops infertility. The person develops infertility. All right. Then what are the effects of FSH and LH here? I already discussed that the Sertoli cells help in germ cell maturation and they help in spermatogenesis. In adults with bilaterally undescended testis, FSH secretion is elevated. So if suppose you have got, say suppose this is the hypothalamus, this is the pituitary, hypothalamus, pituitary, and then we have got the penis and the scrotum. All right, so with testis here. All right, so this is the testis. Say suppose there is some disease of the testis. Say suppose there is some disease of the testis. What will happen to the pituitary hormones, the FSH and LH? The negative feedback is gone and these FSH and LH are increased. So in testicular disorders, if you check the serum levels of FSH and LH, the serum levels of FSH and LH secretion is probably elevated because of decreased Sertoli cell production of inhibin. All right, because of decreased Sertoli cell production of inhibin. The testosterone secretion by the Leydig cells, the testosterone secretion is low. So if you check the testosterone levels, it is low. In one condition, the testosterone level is low and FSH and LH is also low. In those conditions, you can see whether there is some problem with the pituitary or the hypothalamus. So we call it central type of infertility and we call it testicular type of infertility. So two different types of infertility, you differentiate based on the FSH and LH values. If it is increased, patient has got peripheral type. If it is normal or decreased, it means that patient has got central cause of infertility. All right. So we have seen because of dysfunction, sometimes what happens is people develop hypogonadism, primary hypogonadism, pituitary hypogonadism, hypothalamus hypogonadism, that is called as Kallmann syndrome. Then in case of patient who is taking anabolic steroids from outside, so such cases you can easily differentiate based on the levels of FSH, based on the levels of testosterone, based on the levels of the sex steroids, that is testosterone or estrogen, LH and FSH can differentiate. All right. So primary hypogonadism, that is because of testicular failure, you find the testosterone to be low and FSH and LH to be high. Pituitary hypogonadism, you find testosterone low and FSH and LH low. Hypothalamus hypogonadism, what will happen? You will find all the three low. And in hypothalamic hypogonadism, GnRH levels are also low. Gonadotropin releasing hormone levels are also low in case of hypothalamic hypogonadism. We call it Kallmann syndrome. Kallmann syndrome. Kallmann syndrome. All right. So this completes the topic of the male reproductive system. Now let us try to interpret and understand the female reproductive system. All right. The female reproductive system, we'll try to understand the menstrual cycle, we'll try to understand the various types of infertilities that are encountered in a female, and we'll try to understand FSH LH regulation here. So first we'll start our discussion with FSH and LH regulation. So here we have got hypothalamus, we have got a stalk, and we have got a pituitary gland. The pituitary secretes LH and FSH. LH and FSH. The gonadotropin releasing hormone from the hypothalamus preoptic nucleus comes and stimulates the pituitary gland to release LH and FSH. The LH and FSH, they act on the ovaries. they act on the ovaries. So follicle stimulating hormone, the name itself indicates that it helps in the growth of the ovarian follicle. So ovarian follicles have receptors for growth, and it helps in the growth and development of the ovarian follicle. Apart from this, its main aim is to check the estrogen levels. Whereas LH acts on the ovary to produce androgens, ovarian androgen. This ovarian androgen is converted to estrogen, and this estrogen is released by the FSH cells. So especially the granulosa cells, they are producing androgens. The primary ovarian follicles, they produce the estrogen, and this is released into the circulation. High levels of circulating estrogen causes it causes a positive feedback on FSH and LH. So it causes a positive feedback on FSH and LH. A positive feedback on FSH and LH. So please remember, what happens is there is a pulsatile release of FSH and LH. There is a pulsatile release of FSH and LH. Because of this pulsatile GnRH, pulse form of GnRH causes pulsatile FSH and LH surge. This LH surge is responsible for ovulation. Because of ovulation, what happens is the cells of the follicle becomes corpus luteum. Luteum means yellow. So the color of this follicle has become yellowish. So we call it corpus, means group of cells. Luteum means yellow. It starts producing what is known as progesterone. So once the oocyte is expelled out, this oocyte or the ovum is in search of the sperm, and if at all sperm is present, fertilization occurs in the fallopian tube. What happens is every month this ovulation is occurring because of LH surge. Because of LH surge, ovulation occurs. Because of that, corpus luteum is formed. Because of that, progesterone is secreted. Because of progesterone, what's happening is there is growth of the endometrium. Growth of the endometrium. This growth of the endometrium occurs for around 2 weeks, and suddenly what happens is, if pregnancy does not occur, there is fall in the level of FSH, fall in the level of LH, fall in the level of estrogens. Because of this, what happens is there is sudden withdrawal of this estrogen progesterone physiologically, resulting in menstruation. So we will discuss now in detail what is the importance of menstrual cycle. Menstrual cycle can be divided into important phases. Like we have got follicular phase, the first 2 weeks where follicle grows, ovulatory phase, then the luteal phase, then the menstruating phase. All right. So what happens in follicular phase? So initially what happens, there is a small follicle in the ovary. So suppose this is the ovary, multiple follicles are there. One follicle becomes a prime target by FSH, and this follicle starts growing. This follicle is harboring the oocyte. This oocyte gets expelled at the time of ovulation. At the time of ovulation, the oocyte gets expelled, and and this result as a result of LH surge. As a result of LH surge. After this, what happens is this becomes a corpus luteum. We call it luteal phase. So we have got a group of cells, yellow in color, and producing progesterone. You are calling it as luteal phase. This luteal phase is responsible for the growth and proliferation of the endometrium. But sudden withdrawal of hormonal support because of failure of pregnancy to occur, what happens is there is sudden shedding of this grown out endometrium, and that results in the necrosis and shedding off of the endometrium which was grown. That results in menstruation. All right, that results in menstruation. So initially follicular phase is because of elevated levels of what? Elevated levels of FSH, increasing levels of FSH. So this follicular phase is because of FSH. All right, one follicle out of these is selected which has got greater growth, and it starts secreting more and more estradiol. Estradiol promotes and increases the sensitivity to FSH. That's what happens. One follicle starts growing, and one fine day, when its growth is complete, ovulation occurs. And ovulation is because of the LH surge. LH surge. So if you draw a graph of days from 0 to 7 to 14 to 21 to 28, something like that, the initial phases of the cycle up to 7 days, 5 to 7 days of the cycle, we call it the menstrual phase. So here we have got shedding of the epithelium. All right, shedding of the epithelium. From the day 7, slowly the epithelium starts growing. Slowly the endometrium starts growing. From day 14, the growth is very, very high. All right, the endometrial growth, it has got blood vessels proliferating. All right, these are the blood vessels, say suppose. So blood vessels are proliferating, and we have got huge tall columnar cells in the endometrium under the influence of what hormone? The progesterone. So if you draw a graph here and check the levels of estrogen and progesterone, the estrogen levels, they are low initially, and estrogen rises from the 9th day and is peaking to the 14th day. After that it starts slowly coming down, and at 28 days it becomes very, very low. All right, so from 8th or 9th day it peaks, then it becomes very, very low from 20 up to 28th day. If you check the levels of progesterone at the same time, what's happening at the levels of progesterone levels are very, very low in the initial phase of the cycle, but once at 14th day, because of thanks to the corpus luteum, the progesterone levels rise, but one fine day they suddenly come down. So this is progesterone levels. All right, and this blue color is estrogen levels. If you compare this with the FSH levels are maintained at a low pace, but just before ovulation there is a sudden FSH surge. And when you talk about the LH is also maintained similarly, slightly lower than the FSH, but the LH surge is very, very predominant just before 36 hours before ovulation, and again it comes back to normal. So this is FSH, this is pink is LH. So oh, I'm sorry. So this is LH, and this is the pink one is FSH, right? It is because of sudden fall in the levels of LH and FSH. It is because of sudden fall in the levels of LH and FSH. There is sudden withdrawal resulting in menstruation. So this is what is the important scenario of menstruation, menstrual cycle. Now let us try to understand one by one what happens to the theca cell, what happens to granulosa cell and all. Please remember, there is a cell called as theca cell which is under the influence of LH, which has got LH receptors. Via the cyclic AMP mediated mechanism, the cholesterol that is present inside the mitochondria of the theca cell, it is activated by a protein called as steroidogenesis activation regulatory protein, star protein. The star protein is activated. Through various pathways, what will happen is androgens are synthesized. Alright. Out of this, small amount goes to blood circulation and a major amount it reaches the adjacent granulosa cell. Now comes the activity of granulosa cell. Once the granulosa cell is primed by the androgens, this granulosa cell starts responding to the activity of FSH. It has got FSH receptors. So FSH receptors, when they are coupled with they come and act on the granulosa cell, again cyclic AMP activity is increased. Here the cyclic AMP is playing an important role in activation of aromatase enzyme. What is the function of aromatase enzyme? Aromatase converts androgens to estrogen, estradiol, which is an active form of estrogen. Estradiol. Please remember, estrogen is of two types. We have got cyclic estrogen and acyclic estrogen. Whatever estrogen that is formed by this pathway, we develop cyclic estrogen. So any androgen, exogenous androgen producing estrogen, non-ovarian androgen, if it produces estradiol, it's an acyclic estrogen. So androgen which is produced by the granular cell, it is released into circulation, converted to estradiol. Estradiol is released into circulation, and this estradiol, it actually has an activity of inhibition of release of LH and FSH from the anterior pituitary. It inhibits the release of FSH and LH in the anterior pituitary. However, small fraction of estradiol acts locally onto the granular cell and it increases its proliferation. So granular cell proliferation, granulosa cell also secretes a hormone called as inhibin B. So the granulosa cell tumors, it's an important marker. Physiologically, the hormone which is secreted by granulosa cell in very high amounts, you can say that it's a granulosa cell tumor, primary ovarian tumor. So what are the important positive effects of estrogen? Positive effect of estrogen is it proliferates, it helps in proliferation of follicular phase. At the same time, the FSH, which is, the FSH is decreasing. In the follicular phase, whenever the FSH is decreasing, the estrogen takes over and it starts promoting the growth of the follicle. Please remember that there is an inhibitory effect of estrogen on FSH release, is it not? So FSH is inhibiting FSH, the estrogen is inhibiting the FSH, estrogen is inhibiting the FSH, but it is taking over the role of FSH and it is causing promotion of that is growth of the follicle. Please remember that inhibin B, it inhibits the secretion of FSH from the pituitary, but the main role is not clear. Main action of this hormone is not clear. What are the important peripheral effects of estrogen? Let us see. Peripheral effects of estrogen produced by granular cell. The circulating levels of estrogen, it stimulates the female axillary sex organs, and it promotes the secondary sexual characters in the female. It promotes the secondary sexual characters in the female. So rising levels of estrogen causes, so there is a rise of estrogen levels in the initial phase of the cycle. Is it not? I have drawn the graph. So this rising levels, you can see the blue line here, estrogen. So this rising levels of estrogen are responsible for LH surge. Please remember this point. The rising levels of estrogen are responsible for LH surge. The circulating levels of estrogen, during this time, they make the cervix, secretions from the cervix, thin and watery. Thin and watery. So just before ovulation, what happens? There is thin and watery secretion released out from the cervix, which is a marker of impending ovulation. It says that ovulation is near in 1 or 2 days. You can explain this to your patient so as to understand whether really ovulation is occurring or not. Sometimes infertility is because of ovulation disorders. So you can, these are the physiological techniques by which you can explain to the patient and ask her to check the type of secretion she has through the cervix, right? Especially before 12 to 14 days of her cycle. So these are the important peripheral effects of estrogen, right? So how does ovulation, see, please remember that ovulation is approximately 12 to 14 days, around 12 to 14 days of the cycle. In some people, I have seen ovulation occurring very late also. In some people, I have seen ovulation occurring as early as 7th day, 8th day or 9th day also. It depends from the cycle to cycle, depends from person to person. But physiologically, if you ask me, it is 12 to 14 days. In between that time, usually the ovulation occurs. And what is responsible for ovulation? The LH surge. And what is responsible for LH surge? The rising levels of estrogen. Rising levels of estrogen are responsible for LH surge. LH surge is responsible for ovulation. If you want, I'll write it down. Rising levels of estrogen responsible for LH surge, and LH surge results in ovulation. Ovulation. So if this mechanism is lost, ovulation does not occur, and in a follicle, non-ovulatory cycles will occur. That is, the follicle is grown, but it is not ovulating, and hence again new follicle comes in next month. Every day, every month, the follicles keep on getting accumulated in the ovary, different sizes and stages of development, and thus you call it polycystic ovarian syndrome. Polycystic ovarian syndrome. I'll discuss this polycystic ovarian syndrome in my clinical endocrinology later on. But here just I wanted to correlate this finding, right? So at the level of, please remember that in the first half of the cycle, there is a rise in the levels of estrogen. This rising levels of estrogen at one particular level, they are no longer inhibiting the release of LH and FSH. In fact, they stimulate the release of LH and FSH. Negative feedback becomes positive feedback. That results in sudden surge of LH and FSH. The LH surge is essential for ovulation and formation of corpus luteum. Once the corpus luteum is formed, this corpus luteum helps in, this corpus luteum actually revolves around, it starts producing progesterone, and it starts promoting the growth of the endometrium. The follicles rupture 24 to 36 hours following the LH surge. The follicles rupture 24 hours to 36 hours after LH surge. Once you note this LH surge, after this ovulation occurs. After this proliferation phase starts, or the luteal phase starts. So from LH surge to the ovulation, if you see the estrogen, what happen is, you should check the, give me a break for Azan. Welcome back. So it is the rising levels of estrogen which causes LH surge. But after LH surge and ovulation, the estrogen should come down. So what happens is, once you have a patient of infertility, whether ovulation is occurring or not, what you do is every day you check the levels of estrogen from 12th to 16th day. So what should happen from 12th day? It should be reaching peak and it should come down. If it does not come down, it is rising and rising. It means that there is some problem with the ovulation. It means ovulation has not occurred. This lady is suffering from some ovulatory disorder. It might be PCOS, it might be something else. We'll have to again further do tests and try to understand. So this is all about LH surge. Here few points about, see what happens after ovulation is corpus luteum is formed, is it not? The corpus luteum secretes progesterone, and which is responsible for the growth and development of the endometrium. So the corpus luteum, once the ovulation has occurred, the corpus luteum now starts controlling the growth of the endometrium. What are the important effects of corpus luteum apart from endometrial growth? Apart from endometrial growth, it provides nutrition and development of the zygote. So it helps in the nutrition and development of the zygote. Next, it makes the cervical mucus thick. It makes the cervical mucus thick, so that further, if at all the person is undergoing sexual intercourse and sperms enter into the cavity, there should not be second fertilization. To cross check that, nature has created this. Alright, the thick cervical mucus occurs, sealing off of uterus for further entry of sperms, so that no second fertilization occurs till the this zygote gains the development and next menstrual cycle is delayed, if at all pregnancy has occurred. Alright, and one more important point about progesterone is it has got a thermogenic effect. It increases the body temperature. It's a thermogenic hormone. It's a thermogenic hormone. It increases the body temperature by 0.5 to 1 degree Fahrenheit. So these three are important points that are related to progesterone. Progesterone has got a negative feedback inhibition of LH. Please remember this point. Progesterone inhibits LH. Apart from progesterone, the corpus luteum also secretes inhibin. So corpus luteum also secretes inhibin. This time it is inhibin A. Please remember, the inhibin B was secreted by the granulosa cell. Is it not? Granulosa cell. Inhibin B is formed by the secreted by the corpus luteum. What is the function of inhibin A? Inhibin A, it inhibits the FSH. Inhibin B role we do not know, but inhibin A secreted by the corpus luteum, it is causing negative feedback mechanism on the FSH. It causes inhibition or inactivation of the FSH secretion. It's an important point, right? So with all this, I hope that you have understood the menstruation properly. Now let us try to understand how are these female sex hormones metabolized and excreted. The female sex hormones are nothing but they are steroids. Steroid undergoes oxidation, reduction and all these reactions occur in the liver. Alright, oxidation, reduction and all these occur in liver. Apart from liver, other target tissues, peripheral tissues also, the estrogen and progesterone are getting metabolized. Alright. The most important aspect is glucuronide conjugation. It's a type of conjugation reaction. This conjugation increases the solubility of these steroids in the water. It raises the solubility in water. We know that lipid soluble, sex steroids are lipid soluble. They are not water soluble. Its solubility is increased, hence it can be easily excreted in urine. Easily excreted in the urine. Progesterone is converted to pregnenolone and is excreted as pregnenolone glucuronide. Estradiol is converted to conjugate of estradiol, and from there to estrone and estriol. All right, all these are that is the metabolism of estrogen and progesterone. So hope you have understood the importance of male and female sex hormones. I also hope that you have understood few points about the polycystic ovarian syndrome, why does it occur, and a few primary tumors of the ovary which produce which we can detect with the help of finding out serum markers like inhibin B, function of inhibin A, inhibition of FSH, the function of the corpus luteum that to produce progesterone and inhibin A. All these points I've already discussed, so please go through these points. And once you complete this, probably you can correlate the male sex hormone and female sex hormone differences, and thus you can come to a conclusion, right? You come back to me if you have any doubt. I'll be more than happy to help you out, right? Thank you so much. I'll close it.